just a small minority, might actually be cured. So we are actually challenging the dogma here that metastatic lung cancer is incurable. There's a very small proportion that we're talking about, but you have to give these patients the opportunity. And this is a famous trial by Gomez, which is called the oligomers trial. This is oligometastatic tumors, and if you give local regional treatment, you have an improved survival as shown by the solid curve on top. Lastly, I thought I would just talk a bit about oligometastatic versus oligorecurrent versus oligoprogressive. You know, these are terms that you get. So oligometastatic means at diagnosis you've got less than 5 deposits. Oligorecurrence is you've given curative intent treatment, it may be surgery or SABR. You've got a recurrence now in 1 or 2 sites. Again, it's oligorecurrent. The prognosis is good. And you have oligoprogressive diseases. You've got widely sort of metastatic disease. You've given systemic treatment, but the tumor starts progressing in 1 or 2 places. You might find that a liver deposit is increasing, or one of the lung nodules are increasing in size, but the others have responded. Now, these patients, so-called oligoprogressive, also are suitable for local regional therapy. You just target that therapy and hope that the tumor stays dormant for some time. Right? And lastly, I thought I would share this paper that we published on lung cancer survival in the South Asian Journal of Cancer. The data isn't really good. You can see very few patients, less than 10% of all patients were treated with curative intent. And even in the metastatic setting, a lot of patients were treated with 20% just got supportive care alone. Right, in the first line setting, just 3% of patients were treated with EGFR inhibitors because of the fact that testing was not done. It is not available in the state health sector. So these are challenges that we have. But in patients with stage 1 who did have curative treatment, this includes all stage 1 patients, the outcomes are reasonably better. So we need to sort of improve outcomes. We need to offer our patients better treatment across all settings. So just a summary, so small cell, you divide it as limited, extensive, and this is basically what I've said, just a summary of classifications. Thank you very much.
Thank you, Nurad, for your excellent presentation. And it is time for the questions. Nurad, can you explain what is the place for neoadjuvant immunotherapy in locally advanced lung cancer? I think it is important to know about that thing.
Yeah, so that's in stage 3. Recently there was a checkpoint trial. So traditionally we did not give neoadjuvant chemotherapy and surgery. We gave only chemotherapy followed by radiotherapy. But the checkpoint, I think it's 918, that trial showed a benefit with immunotherapy and chemotherapy. Of course, these immunotherapeutic drugs are very expensive. It costs about 1 million a dose. And you need, so it's going to be prohibitively expensive. There is some hope because in India, our Indian colleagues are trying out lower doses of immunotherapy. And the studies are encouraging in certain other tumor types. It has been shown that if you use like 1/20th of the standard dose, you still have a durable response. So if those studies get sort of established, it might be affordable in our setting. But unless the costs come down drastically, it's going to be very expensive here. Yeah.
I'm a little unclear about the squamous cell. You said you look for non-small cell and small cell, and then you look to see whether there's oncogene. So what you said squamous is not. So what is the pathway for somebody who's got squamous cell?
Yeah, so squamous, it's commonly found in smokers. So squamous carcinoma in a smoker, you wouldn't really test for the oncogene mutations. So you would do a PD-L1. If it's more than 50%, then you can go ahead with immunotherapy alone, or you have to give it with, combine it with chemotherapy.
You only do the PD-L1?
Yeah, PD-L1. But if it's like if If it's a non-smoker, even if it's squamous, then it's still worthwhile looking at it. Yeah.
As there are no more questions, we will move on to next topic. Thank you very much, Nurad, again.
The next speaker is Dr. Yamuna Rajapaksa. She is the consultant respiratory physician and senior lecturer, Department of Anatomy, Faculty of Medicine, University of Colombo. And I think she doesn't need any further introduction because she is actively involving up to processes. And she will discuss, talk about diagnosis and staging of lung cancer in pulmonologist approach. This is over to you.
Thank you, madam. I wish this was as easy as last night singing, but I shall try to entertain. Right, so we are talking about a pulmonologist's approach to diagnosis and staging of lung cancer. And before I start, I just want to make a few points clear. As you can see, this lung cancer business is definitely a multidisciplinary effort. None of us can claim to do this alone, so we have to go with all our disciplines together and have interdisciplinary collaboration and cooperation. I know you agree. So the methods that we employ are decided based on availability. As you know, we are a very resource-poor setting. So we need our resources, we need our expertise. Expertise is there, but most of the time the problem is the resources. It should be affordable, it should be safe, and basically it should be patient-centered, depending on the functional status of your patient, and of course, patient preference, that is also key. So going through this diagnostic pathway, more than one method may be used. If we don't get a proper sample, adequate sample size, as Nurad showed the importance of a good sample. If we don't get enough sample from one procedure, we move on to another, and so forth. So we may employ a whole range of procedures from very minimally invasive to fully invasive or surgical. And we must remember, I'm telling this in the interest of all the trainees here, not one size fits all. And this is very true, not only for the patient, but also for the practitioner. Okay? So keeping that in mind, let's see where the pulmonologist is. So I believe the pulmonologist should be in a central role, not in terms of doing everything on their own, but in terms of being the key figure that people keep referring back to or asking back, or your patient needs to come back to you at some point. And you should be like the primary caregiver, because in our setting, family practice or GP practice is still coming up. So we don't have really set GP areas to send our patients to. So until that happens, the pulmonologist should be the contact person at all times. So we get our patients from many avenues. It's mostly referrals from physician colleagues, surgeons, from GPs, and here we do get a lot of self-referral patients. So once the patient comes to us, now this is on suspicion of lung cancer, we do a triage system. All of us do this, and we address urgent issues first, and then we do two things simultaneously. So we send them, we plan booking diagnostic tests and procedures early, because sometimes in the government sector we need to have a time limit. There's a lot of heavy workload, so we have to plan as early as possible. And at the same time, we have to organize and conduct our MDMs. So it is basically the pulmonologist who organizes the MDM here. So you can see who's involved in the MDM on this slide. The radiologist, pathologist, oncologist, and surgeons are extremely important, and where available, our lung cancer, we don't have specific lung cancer nurses, but the nurses are also involved. So with the MDM, the rest of the management goes hand in hand. So we plan management. So after organizing tests, procedures, we do the planning of management at the MDM with our oncologists and surgeons, and we send them for treatment. Now, once they go for their specific treatment, as illustrated before, certain complications we can manage, things like pneumonias, obstructions, we still don't do a lot, but we can reduce the burden of our surgical colleagues by doing things like that, procedures like that, and managing or planning further tests as they appear. So if there's like a metastatic deposit appearing later on in the patient's history, we have to be consulted again, because it's always better for one pulmonologist to have their base of patients, even while referring here and there. And of course, so this is part of the follow-up. So again, for the trainees, I've said this before, when confronted with a possible lung cancer patient, have these questions in mind. How did I get this patient? Where did they come from? And what is my role? So sometimes they come for treatment, sometimes they come for planning of management, sometimes they just appear. We don't know why, they don't know what they have, we don't know what they have. So it's at the very beginning level. How far along the diagnostic process are they? Then what do I do next? What is the stage? Why did they present late? If presenting late, that's a very common scenario here. And most importantly, do they know they have lung cancer? We do not want to be the person who shocks the daylights out of them. So we find out how far they know what they have. And where do they go to? And again, we also need to identify who their primary caregiver is. I know I said we have to have a central role, but we do have to respect where they came from, as in the physician or the caregiver they came from, because we have to always liaise with them. And then what is their family support level? And do they have provision for palliative care and social support, as well as end-of-life issues? So all this should be addressed, or at least run through your minds at the first visit. Having said that, we'll just look at some of the diagnostic tests and procedures that are available to us. So we have the non-invasive, the minimally invasive, the surgical, and of course, other ancillary tests. So the non-invasive would be chest X-ray. We still do chest X-ray because that is the most prevalent available test we have, and it does give a fair amount of detail to us, especially in our setting of tuberculosis. If it's only just to exclude that, we need to do our chest X-rays. Then moving on to the contrast enhanced CT scans, chest definitely, and then after we've figured out the clinical staging from all of those, we go for the other regions to increase our clinical staging. So head, abdomen, pelvis. Then PET scans as needed, and we very rarely do MRI, only if it's really needed for maybe superior sulcus tumors and such, but we don't do MRI very often here. Of course, the minimally invasive procedures are many, and when we think of our setting, mostly we employ the CT ultrasound-guided transthoracic biopsy. So whatever nodules which are peripheral, our radiology colleagues very happily take biopsies from. It is when the tumor moves more central that they seek our assistance. Definitely, if they're opening into an airway, they ask the pulmonologist again. So this is the importance of the MDM, where we look at exactly where the tumor is, and then we discuss with each other and find out where to go. So the other test would be bronchoscopy, which everybody does, and it's available in the main centers, so that's not an issue. Pleuroscopy, also commonly employed test by us. Then the EBUS. Now, coming to EBUS, that is a problem. We only have 3 centers and 1 private, so 4 centers in the country. Some centers are coming up, thanks to our colleagues who are very proactive in getting this done. But as you know, we went through a big economic recession here, and it's a bit hard to get this equipment down. But we do have the training. Almost everyone who has come after foreign training has done EBUS. We recently concluded a really good workshop where all our trainees got a chance to have a hands-on experience, and I'm sure they are interested in us enough to go and pursue this in the future. So I envision a lot more trainees who will know how to do endobronchial procedures, sonography procedures in the future. And we will try and get the equipment for you all. However, this is a main minimally invasive test that we have to employ, as I'm going to show forward. Now, surgically, we have cervical mediastinoscopy in a lot of places. We do use it a lot. I'm sure Dhammika can tell you much more on that, and also Sumudhu, the next speaker. Then, so the surgical procedures, I'm not going to talk of what I don't know, but all these can be employed for us to obtain diagnostic material and also for treatment. So mainly surgical procedures are for the process of treatment and surgical staging, not just obtaining little diagnostic biopsies. And of course, at the outset, we need to plan, because we need to plan either radiation therapy or surgery. All these other tests are needed in order to have a clear picture of patient's functional status. So the NICE guidelines for diagnosing and staging lung cancer gave us some factors to consider when choosing tests for diagnosis and staging. So I think this first sentence is really important. We need to choose investigations that give the most information about diagnosis and staging with the least risk to the patient. I mean, say that 5 times to yourself. We do this, and I know everyone does. So think carefully before performing a test that gives only diagnostic pathology when information on staging is needed. So if you can do a test which does both, please do that test if it's available. If you cannot, please go for the one which is easily available, and then we'll decide on staging. But I think this highlighted sentence needs to go through your heads, and that is why we try to employ such procedures as much as possible. So again, going back to Nurad's talk, adequate samples are needed. But having said that, we do not take adequate samples at risk to the patient without unacceptable risk, adequate sampling, and this should permit the pathological diagnosis and tumor subtyping and predictive markers, because we obviously need it for treatment. Then this gives an indication of when MRI should be done. And also the guideline basically says offer EBUS-guided TBNA for biopsy of paratracheal and peribronchial intraparenchymal lung lesions. I put in this sputum cytology here because, again, we do have places where none of this is available. And if so, and if you do think it's a central tumor, inner airway, patient presents to you with hemoptysis, etc., please do your sputum cytologies. It still has some value here. So do not do these tests. Right. So that's diagnosis. So why do we stage? So mediastinal staging is extremely important, as shown here. You can see with the staging, as it gets worse, the survival gets poorer, extremely poorer. And again, our previous speaker was speaking about the staging and the treatment offered. So obviously stage 1A, 1B, surgical resection, and SABRE, which is, I think, available in the private sector, and it's still coming up in the government sector. But if it's available and if you find your patient at that stage, you have to employ this. So mediastinal staging is needed. Then as we go down the list, stage 2 or 3, it's for surgical resection, adjuvant therapy, the inoperable stages also. So, I mean, how do we stage this? It's via mediastinal and extrathoracic methods involved. So the non-invasive procedures are what we go for first here. CT will give you a lymph node size, on CT, if it's a lymph node of more than 10 millimeter, we can think that there is metastasis involved, but the sensitivity and specificity are pretty low. Then if it's PET scans, yes, they're very good for assessment of occult mets, very excellent. But in mediastinal staging, it's not really good enough, especially because there are a lot of false positives as well as false negatives which can occur. So this will show you that we need to do CT and PET CT to exclude distant mets, but PET CT alone may not be that good enough. So as you can see, false positive PETs can be found in TB, especially sarcoidosis, anthracosis, etc. And you can also get some false negative nodes, especially in a well-differentiated adenocarcinoma histology. So basically, the point here is that you really need to have tissue confirmation. So if you're going to do mediastinal staging, we need to employ something which gives you a tissue diagnosis as well, tissue confirmation as well. So here is where we go to this spoiler. The Mediastat trial, which is concluded recently, actually said that we should say goodbye to mediastinoscopy. I'm not saying we should, literally, because in our country it's extremely important, as Namika would tell you. The thing is, I also believe that surgeons have a huge workload here. We don't have very many thoracic surgeons. So if we can share our burden, I mean, that would be brilliant. So if we go for more, so this trial actually showed that the combination of EBUS and EUS together gave the same results, if not slightly better results, than mediastinoscopy alone. And mainly in our setting, it basically releases our surgical colleagues to do the better procedures, like surgical wedge resection, lobectomies, pneumonectomies, a whole heap of things they can do. the European Society of Thoracic Surgery gave these guidelines, and even there, I don't know if you can see this slide. Well, it's not very clear, but they do show, so if your mediastinal lymph nodes are negative, basically go for the EUS, EBUS, or the mediastinoscopy, but they encourage the use of EBUS and EUS more. Just explaining it a little bit more, mediastinoscopy was the historical gold standard, but sensitivity of EBUS alone was 89% and NPV of 91%, and EUS endoscopic ultrasound gave similar sensitivity, and the two of them combined, you can see sensitivity of 91%, specificity of 100. So I mean, if you have two tests which are more invasive and less invasive, requiring general anesthesia, undergoing sedation, I mean, it's always better to see if you can do the less invasive test. Then, so this is just showing what EBUS TBNA does. Y'all all were able to get a good hands-on experience, and I mean, it's not a difficult procedure to perform. It's very quick. It's very, it's pretty harmless to the patient, and it's a day procedure, right? Whereas surgical procedures take a bit of time for recovery as well. So the other thing which is I think in favor of EBUS is that we can sample several nodes pretty easily rather than going into certain areas. There's problems with other trauma going on. So as we physicians, we cannot afford to cause a lot of trauma within the mediastinum. So this would be a good test for us to use. So if it's an N0 tumor on PET scan, the risk of mediastinal involvement is less than 20%. If it's N1, 25% risk of mediastinal node involvement. So in this case, it's EBUS TBNA can be used very well to detect the nodal disease. There are certain practical approaches as shown here to staging with EBUS or endosonography, both EUS and EBUS. So if you have an idea of these things, if it's a central tumor, if the primary tumor is more than 3 centimeters in size, if it's N1 disease on PET, and if it's a high uptake tumor, then the risk of increased occult mediastinal disease is high. So in these patients, if you see a suggestive node, it's always better to go and get your tissue confirmation in with the least possible problem to the patient. So I will talk a little bit about the process of acquiring multiple nodal sampling, because I've had a lot of questions from the trainees for this. So for example, if you take this picture and your tumor is on the left side here, then our N1 nodes are going to be the ones in green. N2 is the orange, which are the paratracheal and the subcarinal. It's clearer in this picture. I will talk about that later. And your N3 nodes are going to be the nodes on the opposite side, hilum, paratracheal, as well as supraclavicular nodes. So if we want to sample multiple nodes on an EBUS, what we do is we go and look at the worst case scenario for the patient, in the sense if they have an N3 node positive, that's the worst possible outcome. So we sample it first. If we go and sample the N1 node, there is a high risk of that being positive, depending obviously on the other things I talked about. If it's positive, we are going to contaminate our needle, and we wouldn't know for sure whether the N3 positivity you get later on is going to be an actual positivity or a false positive. So we go for the furthest lymph node from your primary tumor. It's the same on the other side. So we will sample the right paratracheals and the right hilar. Then we move on to the N2s, the subcarinal and the ipsilateral paratracheal. And finally, we are going to sample the ipsilateral hilar node. So it's easy to see. Now, there's the issue of, why subcarinal, which side does it belong to? So if you go through this picture, these lines will indicate N1, that is tumor on the right side. N1 will be with a line drawn across the right main bronchus. N2 is going to be within these two lines, so you can see how it's the paratracheal, ipsilateral, and the subcarinal both fall into N2, and N3 is beyond. So I hope that was clear. So these slides, I don't really need to go into detail. It's just showing EBUS, the fact that the direction of view is getting better with the newer scopes, and Fan tells me that the later scopes are actually very thinner, much thinner, so the current scope can only go into the main bronchi, and the newer scopes can go further into there. So it's going to be an absolute game changer because of that. In this picture, you can see the green lymph nodes are the ones that are so far accessible by linear EBUS, even the scopes we have now. So definitely we do the tracheal, paratracheal, the main peribronchial ones, and of course we have access up to the 12 stage. The ones in purple are not accessible, but definitely with EUS you can access those. So some features on sonography which support malignancy would be the shape, the margins of the node, distinct margins, heterogeneous echogenicity, I may have shown a few of you, and the presence of a coagulation necrosis sign. So a sign which is not for malignancy is the septation, which we saw recently at the workshop. If it's septate, it's most likely a granulomatous process. So just a few more slides, I'll finish quickly. So these just show surgical options, which will be probably in the talk by our surgeon later on. A chart which shows which lymph nodes that are accessible. Little bit, I'll just stop a little bit here. So the mediastinoscopy is historical standard, useful when high clinical suspicion is there, and definitely when EBUS or EUS fails, right? We need the surgeons for this. We can't do this on our own. If we fail, we need to get our tissue from any method possible. Then the EBUS TBNA, EUS FNA together will give you all these nodes. So basically, the learning point, the take-home message is the two procedures, EUS, EBUS together versus mediastinoscopy, they're equally good, but in the sense of patient hospital stay, least invasive, we would, at least if our centers are there, we should definitely go for the EBUS first. And if we do fail, which we do fail for things like lymphomas and granulomatous procedures sometimes, then we can ask our surgical colleagues to help us. So do we say goodbye to mediastinoscopy? Well, I don't think so, not yet in terms of our country, but that seems to be the trend the rest of the world. So in conclusion, the pulmonologist's role is as a central caregiver. This is the main message. I'm not going to talk about procedures much. And the diagnosis and staging go hand in hand. So if you do know a procedure which does both for you, please do that. Then mediastinoscopy can be omitted, but it is definitely essential, especially if other things fail, of course. Then the current recommendations are these. I've mentioned this before. So be wary of the N1 positive patients, large tumor size, central location, high uptake, and the non-squamous histology. So final slide. This is the first EBUS we did in Sri Lanka. You can see a few familiar faces here. And of course, this is the first time Fan visited our country with Julia, who was the EBUS nurse. And they did a major training session in theater, the first time any of us had the experience. And this is Dr. Amita, he's not here today, but him trying out EBUS. Oh, he's there. Yes, sir. Hands up, yeah. So yes, thank you for everyone, all my trainers, and thank you for a lovely audience.
Thank you very much for the excellent talk in the pulmonology role in the lung cancer. Thank you very much. We'll move to the next.
We'll move to the next topic. Now, next topic is current perspective in management of lung cancer. To talk on current perspective in management of lung cancer, we'll welcome Dr. Buddhini Karunaratne, consultant oncologist at District Hospital, Kshilao. Over to you, Buddhini.
Thank you, Dhammika. Good morning, everybody. Thank you for the kind invitation, and it's my pleasure and privilege to present on this topic, current perspectives in lung cancer management. Previous speakers actually set the stage for this talk, and this is a very broad topic. I will focus mainly on non-small cell lung cancer management. So I hope to discuss novel treatment agents we use in non-small cell lung cancer management, and briefly on application of radiotherapy. And we'll look at what are the neoadjuvant, which is preoperative, or adjuvant, postoperative strategies we use in early stage non-small cell lung cancer management, and new trends in management of stage 4 disease. So I think we all know lung cancer, when you look at the global data, lung cancer is a leading cause of global cancer incidence and mortality, accounting for an estimated over 2 million diagnoses and 1.8 million deaths. So even in Sri Lanka, it's a common cancer, and it's a major health problem globally as well as locally. So I think Nurad, the emphasis on the importance of identification of molecular subtypes, especially in non-squamous histologies. And it's very important that we identify these molecular subtypes, especially EGFR, ALK, ROS, and BRAF, because there are approved targeted treatments we can use in these different subtypes depending on the driver mutation. So there's, especially with emergence of targeted treatments and immunotherapy, the management of lung cancer has transformed. And if I talk about immunotherapy, it's a very smart way of treating lung cancer, because unlike chemotherapy, it would not directly act on cancer cells. It would stimulate host immune system to act against cancer cells or recognize and kill cells. So it's a kind of precision medicine, and we look at the PD-L1 marker present in cancer cells to sort of identify the response to immunotherapy. So it has, the side effect profile is different to chemotherapy. It mainly causes immune-mediated toxicities, basically inflammation of the organs of the body. Most of the patients, they tolerate this treatment fairly well, but some can develop grade 1 to 2 toxicities, which could be managed with low-dose corticosteroids. But some patients, few patients could develop grade 3 to 4 toxicities, which may need treatment discontinuation. So monitoring of these patients while they are on immunotherapy is very important. So when we talk about the therapeutic landscape or clinical application of immunotherapy in non-small cell lung cancer, we have actually gone from more advanced disease to the earlier stages. So paradigm in oncology is we test these agents in the advanced setting as salvage treatment, then in advanced setting as frontline treatment, then we move to earlier stages. So we'll have a look at treatment overview of non-small cell lung cancer. Stage 1 disease, typically treated with surgical management. If patient is not a good surgical candidate, we would offer SABR, stereotactic ablative radiotherapy. It's a very important curative intent modality treatment in early stage non-small cell lung cancer. We deliver very high doses to restricted volumes. We generally use a few fractions of treatments over limited period. We have enough data to say it's a safe and effective treatment modality for medically inoperable non-small cell lung cancer management. Stage 2 patients, we offer surgical management followed by adjuvant therapies. And stage 3, we know, stage 3 consists of heterogeneous group of patients. A vast majority of these patients have unresectable disease. The standard of care is concurrent chemoradiotherapy plus or minus immunotherapy. The patients who are good candidate for surgical management, we would go ahead with neoadjuvant therapy followed by surgical management. So stage 4 patients, unfortunately they have metastatic disease, we would consider or they require systemic treatments, either with immunotherapy, chemotherapy, or targeted treatments. So before discussing about new data, we'll look at the historical data, the LACE meta-analysis, which was published in 2008, which evaluated the role of benefit of adjuvant chemotherapy in resected non-small cell lung cancer. It essentially showed small but statistically significant benefit with addition of chemotherapy. This became the standard of care, but we know most of these patients, they recur and they have progressive disease. So many trials looked into improving outcomes of these patients, and one such trial is ADORA. This ADORA clinical trial is a phase 3 clinical study which looked at the role of EGFR inhibitors in adjuvant setting or post-operative setting. So osimertinib, which is a third generation TKI EGFR inhibitor, which is a standard of care for metastatic disease, EGFR mutated metastatic disease. But we didn't know its role in adjuvant setting. So this trial evaluated stage 1B to 3A non-small cell lung cancer patients who have EGFR mutation. After surgical management, they were randomized to receive osimertinib or placebo for 3 years. Some patients receive adjuvant chemotherapy before targeted treatments. Here you can see striking DFS data. So improved disease-free survival with addition of adjuvant osimertinib. Hazard ratio 0.17. And at 2 years, you can see 90% of patients in the osimertinib group is alive and disease-free compared to 44% in the placebo arm. So this trial led to the approval of osimertinib in adjuvant setting for EGFR mutated resected non-small cell lung cancer. More recently, we saw the disease-free survival has translated into an overall survival benefit with hazard ratio 0.49, and this trial led to the approval of adjuvant osimertinib. And this is the first ever trial looked at targeted treatments in early stage non-small cell lung cancer. So we look at the next new strategy in adjuvant setting or post-operative setting, which is EMPOWER 010 study, which evaluated the role of adjuvant immunotherapy in early stage non-small cell lung cancer. So this trial also included stage 1B to 3A non-small cell lung cancer. They went on to receive adjuvant chemotherapy, then they were randomized to receive immunotherapy, atezolizumab, and best supportive care. They looked at disease-free survival. Here you can see it's a positive study for disease-free survival, especially for PD-L1 positive stage 2 and 3 disease. So this trial led to the approval of adjuvant immunotherapy for stage 2 and 3 patients who have high PD-L1 expression. So the other improvement in lung cancer management is neoadjuvant chemo-immunocombinations in early stage non-small cell lung cancer. CheckMate 816 study looked at the role of neoadjuvant immunochemo combinations. So this trial again included similar patient cohort and randomized to receive immunotherapy and chemo combination or chemotherapy, which is a standard treatment. Then they went on to have surgery plus or minus adjuvant treatment. So they looked at two primary endpoints, complete pathological response or event-free survival. So here you can see improvement in event-free survival with adjuvant addition of immunotherapy and chemotherapy in early stage non-small cell lung cancer. So this trial also showed that improvement in pathological complete response with addition of immunotherapy and chemotherapy. So neoadjuvant strategies have been kind of new setting in lung cancer, but in breast cancer and other cancer types, we have used it very with very promising results. So pathological complete response, it indicates the responsiveness to neoadjuvant treatment, as well as it gives information on long-term prognosis. Here you can see 2% of patients achieved complete pathological response with chemotherapy alone compared to 24% with immunochemo combination. So this trial led to the approval of immunochemo combination in preoperative or neoadjuvant setting. Moving on to stage 3 unresectable non-small cell lung cancer management, we know the standard of care is concurrent chemoradiotherapy or definitive platinum-based chemotherapy with radiation. So this trial looked at the role of addition of consolidation immunotherapy, durvalumab, for 1 year after definitive chemo-RT. So this trial showed improvement in progression-free survival, as well as improvement in overall survival by about 10%, hazard ratio 0.72. So this is a major advancement in lung cancer management. This is a practice change in trial, and this established a new benchmark in management of stage 3 unresectable non-small cell lung cancer. So far, I discussed more exciting data in early stage lung cancer management. And with these newer strategies, hopefully we can cure more number of early stage lung cancers. Moving on to stage 4, management of stage 4 disease, the standard of care is platinum-based doublets. We have been using different platinum doublets, and they perform similarly in terms of survival and time to progression. So with the emergence of targeted treatments and immunotherapy, actually these agents have transformed the management of stage 4 disease. So this slide summarizes the current approach to first-line treatment of patients with advanced non-small cell lung cancer. I think Nurad also elaborated on management of how we manage patients with driver mutations. So if patient has identifiable driver mutation in stage 4 disease, he or she would go on to receive the targeted treatment as the first-line treatment. And if there's no recognizable molecular alteration, we would look at the PD-L1 status. If PD-L1 status is more than 50%, those patients have 2 treatment options. One is immunotherapy monotherapy, which actually allow us to use chemosparing approach. The second treatment is chemotherapy and immunotherapy combination, where we use the synergistic effect of both these agents. And we use immunochemo combinations, especially in patients who are asymptomatic or who needs rapid response or who have high disease burden. So patients with less PD-L1 expression or low PD-L1 expression, less than 50%, still we could use immunochemo combinations in these patients. So here you can see we have kind of multiple targeted treatments approved for stage 4 non-small cell lung cancer management. And most of these targeted treatments actually show 70 to 80% response rate, and they are less toxic, compared to traditional chemotherapy. And they come as oral form, so it's a very convenient thing for the patient. And most targeted treatments show good CNS penetration, and CNS progression is less. So here we see a paradigm shift in oncology where or lung cancer management, targeted treatments have replaced chemotherapy as the preferred line of treatment. So this is a rapidly growing area. So this slide would be more and more crowded with findings of newer studies. In summary, we have seen many advances in early stage non-small cell lung cancer management. We could use adjuvant treatments, the targeted treatments in adjuvant settings. We could use immunotherapy in preoperative as well as postoperative settings. SABR is a safe and effective treatment modality for medically inoperable early stage non-small cell lung cancer management. And consolidation immunotherapy, it improves outcomes of stage 3 unresectable non-small cell lung cancer following definitive chemo-RT. And we have got many treatment options for stage 4 disease, and immunotherapy and targeted treatments have improved survival of these patients. Thank you.
Thank you, Buddhini, for your excellent presentation.
Good morning to all of you, and sorry for the technical issues and all. So I'm going to give a brief discussion on surgical management of lung cancer in Sri Lankan setup. And I think the previous 3 speakers has given good ideas about how to do this lung cancer management in Sri Lankan setup. And so I will try to stick with the surgical options mainly. So I have no disclosures with regard to this presentation, and then objectives. Basically, I'm trying to cover the objectives I have mentioning here. And so with regard to the Sri Lankan data, so you can see here one of the articles that we have published recently with the pooled data of 5 years data in National Hospital for Respiratory Diseases, Valisara. And the commonest site of the tumor we found, which is mainly on the right lower lobes and left upper lobes. And as usual, I mean, we found that the adenocarcinoma was the most prevalent cancer in our surgical unit. And again, most benign one was the hematoma, and then metastatic malignant tumor, it was colorectal lung cancers. And this article again gives a data with regard to from one unit with regard to surgical data, a pooled surgical data for more than 1.5 years, and with lung resections, not mainly the lung tumors, but along with the benign as well as malignant lung tumors who has undergone VATS exploration and lobectomy. And the most commonest thing that we can tell is like in our setup, the ICU stay is much more longer. So ICU stay range from 1 day to 10 days in most of the patients. And again, in hospital, ICU post-operative death rate was around 8.9%, which is mainly due to the post-operative lung infections. And as I said earlier, this is not only the cancer lung resections, both cancer as well as benign lung resections for benign diseases. So moving forward, how these patients come to us, I think it was clearly mentioned by the previous speakers, and especially Dr. Yamuna has clearly stated that pulmonologists should play the major role in referring these patients and arranging, staging, and all the other relevant investigations. And then thoracic surgeons, we are at latter part, like helping the team with regard to the surgical interventions. So a majority of the referrals coming from respiratory consultants all over the country, and the only center for thoracic surgery in Sri Lanka is National Hospital for Respiratory Diseases, and then we have only 4 thoracic surgeons to give the service for more than 20 million population in this country. So so respiratory consultants are the main key figures in managing lung cancers in Sri Lankan setup. And as surgeons, we are mainly considering about the resectability and operability. And resectability is one of the key things that should be assessed by a surgeon. So what we try to assess is with the investigation, seeing the patient, history examination, investigation and all, and check whether we can resect the tumor with oncologically acceptable margins and all. And operability is the overall assessment of the patient, whether this patient can undergo surgical intervention, and all the team, multidisciplinary team, should be agreeing with the surgical process. So as Dr. Yamuna, Dr. Nuraj, and Dr. Buddini said, so this is not a single person's work, so it should be done by a multidisciplinary team work, and we have like well-established MDT at National Hospital for Respiratory Diseases, as well as I know that there's a good MDT setup at National Hospital of Sri Lanka with regard to thoracic oncology. So after discussion and with assessing, and then resectability and operability assessment, and then patient comes to us, and then we proceed with surgical interventions. So I'm not going to discuss like staging and all, because it was mentioned previously by the previous speakers. So I would like to discuss some surgical options. So mainly the anatomical lung resections are the one that we do for biopsy-proven lung cancers, and that is a preferred choice of surgical resection. And starting with segmentectomies, lobectomies, bilobectomy, and pneumonectomy, and sometimes we do sleeve resections as lung sparing modality. So approaches, there are open surgical techniques as thoracoscopic lung resection. So nowadays we do more than 90% of, maybe up to 95% of the cases by thoracoscopic technique. And the most preferred technique out with four surgeons, now we are moving towards single incision uniportal VATS technique, which we do surgeries done by a single port. So this is thoracotomy. You can see the picture, thoracotomy, incision, and other one is thoracolaparotomy. And minimally invasive access, you can see three pictures. The one which is on the left side of you is a subxiphoid approach, where the single port inserted through the subxiphoid region, and then we can proceed with surgical resections. And there's 3-port access and a single port access coming from the lateral aspect of the chest. So these approaches are well established in Sri Lanka, and we do like more than 95% of the lung resections by this thoracoscopic technique with good outcome. And I would say like conversion rates are very much low. I would say it is around something like 5%. For all of us, maybe less than 5% of the conversion rate. But the current problem that we are facing is like due to economic constraints and all, we don't have like some of the consumables. So to do these cases with thoracoscopic technique, so we have to convert it to open. So just again, just to summarize, I think Dr. Nuraj and Dr. Yamuna and Buddini has mentioned about the management pathway. So I have here put some like an example of a case. So like early stage lung cancer, when a patient comes to us, as an example, T1 in node MX. So patient is discussed at the MDT, and then we have to come to a decision. So at the MDT, as I have here mentioned, either we have to proceed with guided biopsy, proceeded with surgery, maybe frozen section, then proceeding with a lobectomy, or sometimes we are going for segmentectomy, then later do decide on completion lobectomy. And Dr. Nuraj and Dr. Buddini clearly mentioned that stage 1 lung cancers, nowadays there are a lot of studies coming up from the North America, like USA, Canada, and they are very promising data. The primary lung cancer, the early stage lung cancers can be treated with SABR treatment. And indeed, it is mainly done in USA and Canada, and then even in UK. So they are moving towards that SABR treatment. But all these things should be discussed at the MDT, and then patient-specific management should be given to the patient. In most of the time in Sri Lankan setup, when a patient is having a cancer, patient comes to us and then say, I need to take this thing out. Even stage 4 lung cancer, they come to us and then say, I'm not happy, take this thing out. So it should be patient-specific, and then depending on the resources available in the country, we have to give the treatment modalities. So again, locally advanced, tumor confined to the lung or local regional lymph nodes. And again, I have mentioned here maybe T2N2MX. So Buddhini has clearly mentioned in her previous lecture that a very diverse group, stage 3A, stage 3B. So we have to discuss at the MDT setup. So mainly, we might offer surgery for stage 3A patients, but it is up to the MDT team to discuss. Sometimes we have to go for an neoadjuvant treatment and downstage tumor and go for surgery. Stage 3B, especially we are not happy to resect as a primary modality, but then after neoadjuvant, maybe oncological treatment, they can proceed with surgical intervention. And advanced stages, most of the time, tumor spread beyond the local regional lymph nodes. In 3 nodes, tumor has gone beyond the boundaries that surgical intervention is not the optimal choice. So again, but in those sort of instances, still, patients presenting with pleural effusions, malignant pleural effusions, we can offer some palliative treatment modalities like talc-pleurolysis, and then as Dr. Nuraj said in his previous lecture, there are a lot of studies coming up with the oligometastatic diseases and all, and then oncological treatment can be combined with surgical modalities. And again, sometime we have to proceed with some surgical resections as a palliative resection, especially lung resections when there's like obstructed bronchus, and then we might have to take that part of the lung out because there may be some collections inside infection where the oncological treatment cannot be done. Maybe rigid bronchoscopy and then clearing out the endobronchial tumor and put a stent and sending for the oncological treatment. So in summary, with regard to this surgical data, so lung cancer detection and early stage lung cancer management, I would say still there are a lot of things to do in this country because the patients that comes to our center, we see like them in a very late stages, and Sri Lanka is one of the countries the lung cancer is very highly prevalent, where the second most commonest cancer deaths in males coming from lung cancer. And we are seeing a lot of patients in our clinics, sometimes in their 40s, even late 30s, coming with late stages of lung cancer, stage 4 lung disease, lung cancer. So we have to catch these patients earlier and arrange the appropriate management and surgical interventions. And again, lung cancer screening is not prevalent in this country, but it is a hot topic in other countries, and already North American countries and then Europe, they have already started. So that is one of the things that we can improve in our setup. And surgical-wise, we have shifted from open techniques to minimally invasive techniques, from thoracotomies to thoracoscopic techniques, and then more than 95%, more than 90% of the cancers that we do in our center, we do by VATS approach. And overall morbidity and mortality rates is similar, I would say, like similar to the European centers. It might range from 1 to 5%, sometimes because of the problems that we have with the infection rates and all. But we have fairly good morbidity mortality rates in our center. And I would say, like, in the MDTs and all, there should be like a super specialization in this field, like in respiratory consultant who's more interested in lung cancer management, oncologist, radiologist, pathologist, and all. So then we can have a very good outcome with regard to these patient pathways and management systems. So just for you guys to see, like for the interest sake, these some video clips that how we do VATS lung resections. This again a single port VATS upper lobectomy. I don't know whether you guys can understand the anatomical structures and all. Maybe Dr. Rasnayaka can understand. So this is how we do like VATS lung resections. This single port access VATS right upper lobectomy. And again another video how we do like VATS resection using endostaplers. So currently the problem is like these, some of the consumables are not available in government sector, and then it's very difficult to get it done by thoracoscopically when we don't have the enough consumables. But still we are managing. And you can see that we are resecting the lung with endo GA staplers. Again, this is a single port access and doing a lung resection. So all these techniques are available in Sri Lanka, and with regard to the VATS, it has a very good outcome with post-operative recovery, pain relief, and patient can go home earlier. And with regard to the oncological outcomes, there's no difference in between open resections and VATS resections. It has been proven in the other part of the world. So even UK and USA and all the other countries, they are moving from open techniques to VATS techniques. And for the interest sake, so I have shown, this is not available in Sri Lanka, these some of the videos. These are the newest techniques, this robotic technology. And these from one of the UK centers, which I worked like a few years ago. And these are Da Vinci Xi2 system. And you can see only one assistant is at the bedside, and then the 6 robotic arms. And at the right-hand side, you can see the surgeon in the distant to the patient in a console. And there's another robotic platform. It's slightly different to the Da Vinci system. And again, there's one assistant at the bedside. And the there are 4 robotic arms. And surgeon is operating with distally. I mean, these are not available in Sri Lankan setup. And again, how you see inside, and then this again Da Vinci Xi2 system, and doing a lung resection and all. And so my presentation is over, and if you have any questions, you can ask.
Talk. Now we can have few questions if you have.
Actually, this question is to Dr. Buddini. In a setting like us, where EGFR mutation testing is not widely available, how practical is to give this targeted treatment in these patients?
Yes, Damit, it's not freely done in government health sector, but in private sector, it's, I think, compared to other tests, it's affordable to most patients. I think we generally encourage, if a patient comes with especially non-squamous histology, we would encourage them to get done these tests, because it's very important. We have seen very promising results. And these patients, if we start on EGFR inhibitors, their progression-free survival is better, and their survival is better, and most importantly, quality of life. So they get very less toxicity compared to traditional chemotherapy. And as I mentioned, oral preparation, very convenient. So they have a near normal life. So I think we should encourage all the patients if they can afford it. But at the same time, we should encourage administrators and policymakers that how important the streamlining of diagnostic pathways in lung cancer. It's very important, yes.
In case if this EGFR mutation testings, if the patient can't afford, is there any place of giving this targeted treatment without testing it?
So at the moment, first line setting, I would not encourage starting EGFR inhibitors without testing it. So I think we should have these molecular markers before we start these expensive treatments.
Understood. And this PD-L1 testing that you mentioned, do we have it in our country at the moment?
So there are some universities, they do, especially in Colombo University. Even in private sector, it's not very expensive. It's, I think for most patients, it's a doable thing. Yes.
Thank you.
Thank you very much, Saman, for your excellent presentation. Saman, I have a question. Generally, we know that key to complete cure is that early detection. But current trend is even that we get sometime we receive patients early lung cancers from oncologists because they have referred to oncologists, even stage 1 or 2 lung cancers, which should be resectable. And so what is your opinion regarding that early detection of lung cancer and screening? And so what are the screening protocols which can apply for Sri Lanka?
Yeah, that's a very good question. I mean, as Dr. Rasnaik has mentioned, we do see a lot of patients in our setup, like very early stage lung cancers, and they are referring to us at very later stages. And in like other countries, especially in UK, they have like cancer breach dates, which would be like 4 to 6 weeks maximum. And then everybody has to answer why you haven't done any intervention within this time period if you don't do anything. So in Sri Lankan setup, we don't have such a thing. And again, like cancer screening is not established in our setup, and there are a lot of studies done in North America immigrant centers and then European centers. Even in UK, they have done studies in Liverpool, Manchester, and they have already started lung cancer screening programs. So I think Sri Lanka needs a proper national-wide lung cancer screening program where the targeted population, especially like patients with smoking history and previous ex-smokers and any significant symptoms should undergo basic investigation, starting with maybe chest X-ray, but the ideal investigation of choice is low-dose CT, and then that will detect any lung pathologies. I think we can start from that point onwards, and then referring is very important because we have seen sometimes like early 40s and late 30s. Some of the patients coming with metastatic lung disease, and then they will not survive for the maybe 1 year from that point onwards. And the pathetic situation is like they have gone to at least to a GP center. Maybe some of the respiratory colleagues have been seeing this patient for some time, but detecting very late. I mean, I'm not pointing like, I'm not telling that it's not the fault of anybody, but what I'm telling is like the pattern that we see in this country is different than European countries. Because in Europe, we see like a lot of lung cancer patients like maybe more than 60 years of age. So when we were practicing in UK during our foreign training, we very rarely operate patients less than 60 years. But here, every day we operate like, even like 2 days back, I operated on a patient like 40s. So it's very early age patients presenting with lung cancer and all. And the other problem is like even in small kids, pediatric population, we are seeing this may be related to some air pollutants in this our setup. So we have to be vigilant, and then early referral and proper MDT setup, collaboration in between oncologists, surgeons, and pulmonologists is essential to have a good outcome.
Thank you, Saman.
Thank you very much.
And I have another question from Yamuna on behalf of the audience. What is the average cost of e-bus in Sri Lanka?
Yeah, thank you for that question. So government sector, e-bus is free, right? Because the government pays for the needle. The main cost of e-bus is because of the needle cost. So before the whole recession period, the cost of one of the needles was about 30,000 rupees. I mean, even that is huge. And now it has gone up to 100,000, so 110,000. And I mean, going through not only one type of needle, there are so many other brands of needle, they are all above that. So the cost is mainly governed by that in the private sector. And the other costs, costing is really, really pretty low. Our charges, the hospital charges, because it's a very short-term procedure, so there's no like a theatre charge, a large theatre charge. So they have an admission fee of, I think about, it used to be 10,000, so it's about 20. So in the long run, if as an overall picture, I think e-bus would come to about 150,000. Again, If the needle cost is taken down somehow, then it will be much less. But our hands are tied.
But basically, I know that the consumables cost about that current, according to the Olympus that they're commonly using, system is consumables is around 500,000, 450,000, that single kit. So that even government budget, it affect because generally,
yeah, definitely.
Generally, for our health budget, basically, mediastinoscopy, it doesn't have much cost except that payment for the salaries, and that all are reusable. So generally, even private sector, single mediastinoscopy cost about 250 to 300,000. Whole cost that at the, generally when the patient discharged. So I feel basically in Sri Lanka, we can't say goodbye to mediastinoscopy because we generally, exactly, in addition to that, we do VAMLA, that is, in addition to the sampling, that we generally take all the specimen, we remove the specimen, so it gives kind of survival benefit as well.
Yeah, so that's what I said. So in that setup, definitely you have all those other benefits of a surgical technique. The removal, then you can completely resect all the nodes, right? When you do that. So that is not possible. This is just a matter of sampling. I mean, it's very sad because it was quite an affordable procedure. EBAS was an affordable procedure maybe 2 years ago. Up until now, I mean, it's only now that it has gone like triple of what it used to cost, because we used to do it for a total of 50,000. And now it's just, you know,
yeah, thank you, Amuna.
Gone thrice.
Yeah, but that current situation that we have.
We've had to adapt to a lot of things currently, yes.
Yeah, thank you. Thank you very much. Yes, then we will conclude the session. Thank you very much for the audience as well as all the speakers. It was very elaborative and very nice 4 presentations. Thank you very much.
Thank you for that informative series of presentations. I would now like to invite the chairpersons for this session, Dr. Masaima Fahamuddin and Dr. Dhammika Rasnayaka, to present the tokens of appreciation to the speakers. I would like to invite the speakers for this session back on stage to receive their tokens of appreciation. Dr. Yamuna Rajpaksha. Dr. Nural Joseph. Dr. Buddhini Karunaratna. Dr. Saman Iddagoda. Thank you. I would now like to invite the Joint Secretary of the Sri Lanka College of Pulmonologists, Dr. Damit Rodrigo, to present the tokens of appreciation to the chairpersons for this session. Thank you. Ladies and gentlemen, we cordially invite you to enjoy the tea service, which will now be available outside. The next session will start at 11:30 a.m. sharp.